All right, we'll call our meeting to order. Thank you for joining us tonight. It will be a short meeting, I think. We only have a consent calendar tonight and a couple of presentations, so it will be short, but we will go ahead and get started. Chaplain Grubbs, will you lead us in our invitation?
Shall we take a moment? Here are thanks for our hospital award and for this time and space to share with one another this community of caregivers. Let us break open awareness of how sacred and precious it is to share in work that we care so deeply about. While we give of ourselves, sometimes from the depth of our soul and heart, we likewise receive so many times over back into our own heart. Sometimes it astounds us. We give thanks for our service in Erlanger and all that is here. The fruits of our labors are abundant, and so let us be grateful and good stewards for the abundance we've received. Guide us daily to think, speak, and decide with clarity of purpose and vision in all that we do for healing and hope. Sustain us as we give and receive from one another in ways that benefit the common good, never taking for granted all that we have. With gratitude we pray and give thanks on this evening. Amen.
Amen. Thank you. I think each of you received the agenda earlier this week, and I know of no changes. You have it with you this evening. This evening we're going to start off with a couple of presentations. Terry Ellis, I think we have a presentation of the Department of Defense.
Well, good evening. Thank you for the opportunity to be here. To each of the board members, Mr. Spiegel, I really appreciate this. I'm Terry Ellis. I'm an Erlanger employee. I'm the clinical manager for the respiratory department. In October, I'll celebrate my 20th anniversary here, and earlier this month, I celebrated my 26th anniversary as an Army Reserve soldier. In my current job in the Army Reserve, I'm a career counselor, and even in today's environment where service members are recognized for the service that we have given parts of our lives to serve our country, there are still some employers out there that aren't real understanding about the time that employees take away from their civilian jobs. And there's an organization that I learned about my first year in the Army Reserve called the Employer Support for Guard and Reserve. They really have two primary functions. One, they function as an intermediary between employers and employees when there is a misunderstanding about what the law says and just the ability to offer time to soldiers to be able to serve and other service members as well. I've been very fortunate in the fact that having worked here for the last 2 decades, I've never had any type of conflicts. And another thing that the Employer Support for Guard and Reserve does is recognize employers who've taken that extra step to allow service members in Guard and Reserve units to serve, and a lot of times provide them with continued benefits and compensation they may lose because of their service. And I just want to be able to take the opportunity to say thank you. For these two decades that I've served working here, I've always had support from my boss, my superiors throughout the chain. And at this time, I want to introduce a couple of the gentlemen from the organization for the ESGR who will come forward to present a couple of awards. As they're coming up, I want to take the chance to explain why I've nominated these individuals. My boss, Lisa Caldwell, she is the best employer, best boss I've had in my entire career, having worked since age 15, so the last 30 years. Extremely supportive of me in my role as an Army Reserve soldier. She's gone above and beyond. Anytime I've had schedule conflicts, she's been very helpful in allowing me to work those schedule conflicts out. I can't say enough. So in the past, I have actually nominated her for what's called the Patriot Award, which is kind of the base level award with the SGR. And she's received 3 of those over the last 12 years, last 10 years. And at this time, this year, I've nominated her along with a few of our other executives for what's called the 7 SEALs Award. And I'll let Chris talk about those. But it's just my way as an Army Reserve soldier and an Erlanger employee of saying thank you to these individuals as well as to the health system. So at this time, Chris Cole and Bill Hewitt, if you would, come forward.
I'm the vice chair for the Chattanooga Area Committee. Bill Hewitt is the chairman. I was able to get involved with these particular awards earlier, and it's an honor to be here and let you know how important it is, the relationship that the employers and the Guard members have to have. We could not have the Guard and the reserve forces that we have today without the support of the employers that they work for when they're not on active duty. To be able to just say, hey, I've got to be gone for 2 weeks on active duty for my training, or every weekend, once a month, or, oh, by the way, I've got this training course that I have to attend in order to be promoted, and the employer allows them to do that and promises them their job when they come back without conflict. Yes, there's a law that says you have to do that, but when you go beyond what the law says you have to do, it really is what contributes to us having the reserve force that we have today. So at this point, I'd like to call up Lisa Caldwell. Lisa is Terry's boss, or immediate supervisor, I guess. And it's an honor to present this award.
On behalf of the men and women of the National Guard and Reserve, I want to thank you for your support of Terry.
Mr. Tanner Goodrich.
Congratulations. On behalf of the men and women of the National Guard and Reserve, we thank you for your support of Terry.
Rob Brooks.
Congratulations. On behalf of the men and women of the National Guard and Reserve, we thank you for your support of Terry.
Mr. Kevin Spiegel.
Congratulations. On behalf of the men and women of the National Guard and Reserve, we thank you for your support of Terry and all your other employees and all members of the Guard and Reserve.
Appreciate it.
Gets that one back.
Let me talk about this award a little bit. Not every organization gets one of these. It's called the Above and Beyond Award. And essentially, it's an employer who goes above and beyond what the law requires. So Erlanger is to be congratulated on their support of their employees who are members of the Guard and Reserve. Thank you again.
Thank you. On behalf of all the employees at Erlanger and the Erlanger Board of Trustees, we appreciate your service to our country. And we also want to acknowledge all the other employees who are veterans of our country, who currently serve and who have served in the armed forces. Congratulations.
Thank you, Terry, and thank you, Mr. Spiegel, and the entire management team for going above and beyond. That's it's quite an accomplishment. Thank you. Dr. Kofer is going to have our quality presentation tonight.
Thank you very much, Mr. Hutchinson. It's a real honor to be here. I'm very delighted to have this job, and I thank Mr. Spiegel and Mr. Gentry and others for allowing me to be here. Before I get started, for those of you who don't know me, my dad moved the family here in 1960. I've lived here on and off since that time. I was a medical student here in the 70s. I was a surgery resident here in the 80s. I've been back on faculty since 1995. So Erlanger is my hospital. But before I get started with this brief, less than 10-minute presentation, I'd really like to acknowledge the efforts of Dr. Woods Blake, who's in the back. Woods has done a superb job in this job for many years. He's done it almost one-handed against the foes of calamity. He's seen as the face of quality in this place, rightfully so. And I can't thank him enough for helping me the last 6 or 7 days. And I think that the board really owes him a thanks of gratitude for his many, many years of service with not a lot of support. And hopefully we're going to have more support going forward. And I just want to assure you that he and I are working together hand in hand. I couldn't get by without him. So very quickly, I want to give you maybe a little brief history of my credibility. In 2004, I was sitting in Boston when I heard Skip Campbell present the rollout of the private NSQIP program. This is a National Surgical Quality Improvement Program started by the American College of Surgeons. And I heard that talk and had an epiphany. And I said, man, this is what we need. Surgeons have never had data. They've never had outcomes data that they believed in. And now for the first time, we're going to have actual outcomes data that we believe is appropriate. It's prospectively collected. It's got 30-day outcomes, and it's the best. And we joined in 2005. We were the first. These are the first 3 hospitals in Tennessee, and we were the first one. We were the 31st hospital in the nation to join this. The 31st hospital. And put that in context, this is NSQIP as it exists now. There's over 500 hospitals in the world in it. You can see the 21 here in Tennessee. I'm going to talk about this collaborative briefly. We're considered, I think, the best collaborative in the nation, arguably behind Michigan and Washington State that don't use NSQIP. We're known nationally for our surgical quality in the state. So after we joined in 2005, first hospital in Tennessee, 31st in the nation, we got together in the state and put together a surgical collaborative. And this was formed formally in May of 2009. It was a great occasion. We had Skip Campbell down from Michigan to talk. We had Vicki Gregg from Blue Cross Blue Shield. They were funding this. And we started to collect data. We started with 10 hospitals. These were the first 10. They're listed alphabetically. You can see Erlanger's there. Many of the teaching hospitals in the state were there. And some smaller hospitals like Cookville, which is a small rural hospital. We now have 11. Blue Cross Blue Shield gave us funding to increase from 10 to 21 in about 3 years ago. And so these 21 hospitals have been showcased nationally about this is the way you do quality. This is the way you collect data and give back data. So what are some of the data? Well, these are the hospitals. All 21 are on here. You can see we got in 2005, but we were doing so well, our sisters across town over here decided they better get in. So they joined the collaborative with funding from Blue Cross. This is very briefly, I'm going to show you a few slides, data slides. This paper was presented at the National NSQIP meeting a year ago in 2014, and this was the clinical national winner. We got recognition for having the best paper of the whole country. Brian Daly of Knoxville presented it. We got a nice plaque. And what do we show? We showed that since we've been collecting data, we've dropped complications in 17 out of 20 categories, 9 of them statistically. And these are the statistical improvements: mortality, ARF, ventilators, organ space SSI. It's surgical site infection for the non-surgeons in the room, superficial sepsis, septic shock, UTI, and wound disruption. We improved that 19%. We improved mortality. We decreased an estimated 3.75 deaths per 1,000 cases, and that was statistical. And we avoided costs for $75 million. Graphically, you can show that our mortality, we dropped our surgical mortality per 1,000 cases from just about 28% to about 18%. That's a huge drop. It's a lot of people survive. We dropped postoperative occurrences. This is all postoperative occurrences. We've dropped them from about 200 per 1,000 surgical cases to just over 150. That's real improvement. And that is not only good for patients, it helps the hospital function more efficiently with less cost. And this is where the world is going. Those of us in surgery and other specialties who aren't paying attention to quality, we're going to be left behind. So I'd like to applaud Mr. Spiegel and his concept of forming this quality department. For years, it's just been Woods Blake, Mike Bettinger plugging away, but now we hope we'll have a quality department filled with multiple people trying to make this better. There's our logo. So that was the history. Perhaps that establishes some credibility. So what are we going to try to do now? Well, we're going to try to improve a lot of things, but I've taken on this concept of improving HCAPs. What are HCAPs? Well, they are actually, the acronym stands for Hospital Consumer Assessment of Healthcare Providers and Systems. This was developed by CMS and AHRQ in 2005 and 2004 as a method to canvass the opinions of the consumer in surveys about their experience in the hospital, both the care they were given and their experience. This is all about the patient's experience with and the perception of the delivery of health care. I'm going to try to make this better. So what I've done in the last week is picked a single nursing unit, got into that nursing unit, sort of my home, North Wing 8, South Wing 8, talked to the head nurse, convened a group of nurses, got some concrete ideas about specific things they need. With Dr. Jan Key's help, been able to put some of those into place already, and we're working on it, and they're enthusiastic. And my goal is, quite frankly, stated to them, is to make that unit the best unit in the hospital, improve their patient satisfaction scores through the roof, make all the other floors jealous, and then everybody want to follow those things. So that's sort of a brief history of where I've been, what I've been able to try to do so far, and we've got a lot to do. Any questions? Yes, ma'am.
So we all know the beast that is HCAPS. Can you talk a little bit about what collaboration or support that you and your team will need to make that pilot a success, and what you're hoping to try different to move those scores?
Well, the biggest thing is just to get out there in the field, go talk to the nurses. I plan to roll out. I'm waiting for Dr. Keys to tell all the nursing floors that don't feel blind. I'm planning to start making patient rounds 1 or 2 hours a day where I just pop in on patients' rooms, and patients love it. I was up in the patient's room North Wing 9 Friday because they had a complaint. I went up there and they were blown away that somebody came by in a white coat to say, what was wrong? What can we do to make it better? So that's one thing, is just to simply get out there. Number two, go to the nurses. So doctors get all the credit for stuff, but let me tell you, it's the nurses that get this done. They're the ones that are there, 23 and a half hours out of the day, where the doctor may be there for 15 minutes. I got to go to the nurses and see what they need. And what I did on this floor, for example, they said, what we've got to have is a sacrosanct time to do patient turnover in the patient's rooms. I want them to go and do shift change in the patient's room so the patients can see there and see that interest and see they're talking about them. But they wanted sacrosanct time. They wanted from 5:30 to 6, period, no transfers in. I went to Dr. Keys, she said fine. We went to Adam Rohr, he said fine. So PACU patients will not be coming to North Wing 8 between 5:30 and 6, and the nurses are going to make turnover rounds in the patient's rooms. This is not novel. It's been done other places. They're going to do hourly checks on the patients. They said, we do not want our nurses to get pulled from this floor to go to the ED. I went to Dr. Keys, we put that in place. So it's about talking to the nurses, see what they want. This is a pilot project. It may not work, but I bet it will. And then 6-8 months down the road, when we've given these nurses the resources they need, which is basically just listening to them and doing simple stuff, hopefully we'll make these scores much better, and then the other floors will say, how'd they do that? And we can roll it out. But I think to try to fix everything at once isn't going to work. You got to start small, see what works and doesn't work, and then try to extrapolate that. Other questions?
Dr. Cover, one of the metrics that we look at, and you'll have to help me, maybe it's the HCAPS, I'm not sure, but it's the percent of answers that rank us as excellent, I think.
Right.
Which, that's good, but that really, and I've been talking about this for years, trying to get, if I have a scale of 1 to 10, that's meaningful. If I have the number that rank us as excellent, I could have a whole bunch of them right below that excellent and still feel pretty good about it. Or it's easier to measure improvement if there was some sliding scale rather than that absolute.
Well, I hear what you're saying, Chairman, but the fact is the stuff that Medicare is rolling out to the public is basically excellent or not. And I agree with you from an engineering standpoint or systems engineering standpoint, it's better to go from 12% to 15%. But our goal has got to be to get over 50%. Because quite frankly, they don't show that scale, I don't believe, to the public. They show good, not good. We've got to try to get good for everything. I mean, I've got a meeting tomorrow with the new food service people. I've got a meeting tomorrow with the new janitor people. You know, we've got to start changing this on multiple levels to make this better. Cleanliness, the quality of food. If you look at our HCAP scores on food, they're not that good. And some floors have reasonably good scores, but as a whole, we got a lot of room for improvement. So I think rather than sitting in a room talking about stuff and then sending out a memo and having a meeting, we got to get out there. We got to get out there and talk to the nurses, and then they say, I need a monkey wrench. Go get them a monkey wrenches. Here it is. Now what? And I believe that'll work. I think it's going to take some leadership, and it's going to take the nurses believing that we really want to make things better. We're just not talking the talk. We're walking the walk. And I think we'll be able to get there. It'll take time. I'd say at least a year, maybe 2, but I'm hoping on this nursing unit in 8 months I can show improvement.
Can you come back in 8 months and let us know how you did?
If I still have a job, I'll come back. So. Other questions? Thank you very much.
Thanks, Dr. Coe. And thanks to Dr. Blake for leading the charge so far, and I can assure you, Dr. Kofer, you have a lot of cheerleaders on this board. So
Thank you.
Thank you. You were sent in your package the minutes of June 25th, and I will entertain a motion if there are no corrections or additions.
Move that we accept.
Thank you. Do I have a second?
Second.
Okay. All in favor, say aye.
Aye.
Opposed, like sign. On our budget and subcommittee, our committee and subcommittee reports, Trustee Studer is not here this evening, but Budget and Finance did meet this past Monday, and they have 3 items on the consent calendar. Dr. Miller, joint conference?
We did meet, have no report.
Very good. Mr. Wilson, planning?
We met, but I have no report.
Very good. Trustee Griffin is not here. I don't believe the audit, or did we meet this month, Kitty?
Yes, we did.
I think we did. That's right, because I was there. Audit and compliance did meet with nothing to bring before the board tonight. Legal committee?
Not this month, we did not.
Management board evaluation?
Mr. Chairman, we did not meet, but I wanted to take a few minutes to explain to the board what's getting ready to happen, because we have a few things underway, and we've got some committee meetings coming up. Is that okay?
Go for it.
All right. So 3 things are underway, everyone. First of all, the fiscal year 2015 incentive plan, we will need to vote to pay that out once the audited financials have come through, and once you've had a chance to appropriately review the audited financials. So we have an MBEC meeting coming up in September, and we have a board meeting coming up in September, so you can expect to see some action on that on first the committee calendar and then on the board calendar, and I'll get to dates here in a minute. I would just remind everyone that this is the plan that we voted to put in place a while ago, and so now it is the authorization of the payment because of the value of the payment. So that's what's happening with that one. The second thing that is underway, you should have all just recently gotten an email from Kitty on my behalf soliciting board input for Mr. Spiegel's annual evaluation. That input is an online survey that is managed externally by Sullivan Cotter, and I would ask that you please take some time to fill it out across the multiple dimensions. To assist you in filling that out, in addition to your own observations, we have 2 attachments in that email. 2 attachments in that email. One is just a record of what has occurred at the hospital over the course of the last year, so financial performance, operational performance, government relations, etc., from Mr. Spiegel, so that you have a recap of everything that's gone on to refresh your mind. And then second, we have a report back from Sullivan Cotter, which is a synthesis of input from the medical leadership and from the executive team leadership, where they also conducted a review and gave their input on Mr. Spiegel's performance. And so you'll be able to see the scores that they gave as well as direct comments. They're all anonymous. They are held confidentially as in terms of the records by Sullivan Cotter, but you'll have that to help you as well. I would really ask that everybody fill this out as soon as possible. The survey will stay open until September 8th, which is the Tuesday after Labor Day. So you've got a couple of weekends in here and some business time to do that. Third thing I want to talk about is the dates. So we weren't exactly sure what the timing would be that we'd be able to conduct Mr. Spiegel's review. So initially we had scheduled an MBEC for the 24th of September, right before the board meeting. But because we'll need to take some actions, and I don't want to do that back to back, meeting to meeting, I want to give everybody ample time. What I'd like to suggest is two things. First of all, with respect to the incentive plan, not Mr. Spiegel's review, we would actually take that up as a matter at an earlier MBEC meeting in September. And so I think we're currently looking at a date potentially of September 10th, but I'll circle back around with all the committee members to make sure that works. We'd also at that point like to be able to have a discussion of the process that we use to review the CEO. Since the survey will have just closed and your opportunity to give input will have just closed on the 8th, I don't think it's appropriate to take any action and put that on the agenda for that meeting, but I want to give everyone sufficient time to think about it. So what that means then is that at the board meeting on the 24th, likely, don't know if others will have other matters before the committee, but likely the only item we would potentially be taking action on is to vote to pay out the incentive, vote on the payout of the incentive plan, and any action related to Mr. Spiegel's review and compensation would be delayed until October to give everyone sufficient time to reflect on that and debate. Any questions?
Any questions on that? That's, we just want to get the logistics down between MBAC and the board meetings and give everybody ample time to review all the data and ask any questions that they have any input. Very good, and I'd like the record to show I have already completed my CEO evaluation. I got it today, and I took the time to do that. So usually I procrastinate on everything. I have not on this.
Don, I'm sorry,
Yes.
Mr. Chairman, I forgot one thing. The board evaluation. So we had a self-evaluation where you all took an online survey and also gave comments back. And I actually this morning got the results back of that in a synthesized form. So at an upcoming MBEC, we'll talk about that as well.
Very good. Will that be brought before the whole board or just at the MBAC meeting?
We'll do both. I just want to give the committee a chance to talk about the process too. So if there's anything we'd like to change for the next year, we can sort that out.
Because I'm anxious to see those results. Very good.
I know everybody is.
See how we're doing.
Mr. Chairman?
Yes.
Last year, we considered the bonuses in December. Why are we doing it in September this year? What happened last year that caused it to be delayed so much?
Ms. Stanley might be able to answer that better than I can. I'll try it though. Last year, we had the audit, and because of the timing, and I think it was mainly around Mrs. Stanley's travel schedule.
There were three things happening, actually. One was the audited financials weren't available until a little bit later. Number two, we launched the 360 review of Mr. Spiegel for the first time ever last year, and we needed to give people more time, and we couldn't get it done until October. So that pushed it out until October. Well, we didn't want to give it people in October and then vote in October, so the next option would have been November, and guess what? November we hit on Thanksgiving and the board meeting was canceled. So then my travel schedule was a third thing that came into play, and that's how it all got pushed to December. So this year, one of the things that we've worked very hard on is to establish a calendar that aligns our votes with the release of the audited financials and aligns our votes on an upcoming fiscal year incentive plan before that fiscal year already starts. So Greg, correct me if I'm wrong, but the fiscal year 16 plan is already in play.
Yeah, it has been discussed, yes.
It has been discussed. So that has now happened already this year as well.
What about our audit report? Will it be ready?
Next month.
Will we get a chance to look at it before the board meeting?
Yeah, we hope to have it out the week before the board meeting. That is the goal. It's getting in draft form as we speak.
Correct me if I'm wrong, that should go out with the agenda for the Budget and Finance Committee, which goes out a week before the Budget and Finance.
Yeah, if we get a draft version, we'll push that out to the board members as draft. We haven't received it as yet. As soon as we do, I mean, they couldn't even put that together until we had the pension data, and we have received that. So the auditors are finalizing it. As soon as we get the draft version, we'll push that out.
And we're the first fiscal June 30 entity that they get out. So our team does a really good job in making sure that we meet those deadlines.
Thank you.
Hey, you're right, I forgot, we did, the November board meeting last year fell on Thanksgiving.
Right.
So we didn't have it, so thanks for reminding me of that.
No problem. I remember that.
Very good. And Personnel Committee, I don't think met this month, so is there any other unfinished business? Not that I know of. And you have your consent calendar. There were 3 exciting items on the consent calendar, so I hope everyone that didn't make it to Budget and Finance had a chance to look at them. They all relate to building out capacity here in our hospital, which is very exciting and a much needed expenditure. So that's on the consent calendar. So if at this time I will entertain a motion for approval of the consent calendar. So moved.
Second.
Have a motion and a second. All in favor say aye.
Aye.
Opposed, like sign. Dr. Kern, Chief of Staff report?
No report, sir.
Very good. Management report. Mr. Speaker.
Mr. Chairman, thank you so much. I do also would like to officially recognize Dr. Joe Kofert as our Chief Medical Officer, Quality Officer. Dr. Kofert really has a really rich history as implementing the NISQIP in the state of Tennessee for the first time and really focusing on quality. He's a distinguished surgeon and has served as chairman of the American Academy of Surgery, and a very distinguished career. I mean, this really takes that to the next level. And also Dr. Woods Blake, who is the Associate Chief Medical Officer, Quality Officer, and together they're going to make a wonderful team. We're also going to be hiring an administrator for that department, and we're going to be looking for space of where actually to relocate this new department with staff to support that. And I think it's our commitment to really focus on quality and put the resources to enhance the quality and patient outcomes at this hospital. So congratulations to you all. We also, Dr. Kern, myself, Dr. Dan Fisher, who head up the search committee for a new chief medical officer. We have narrowed that search to 2 finalist candidates, and I'm working with the officers of MedExec and Dr. Dan Fisher, who is the chairman of the search committee, and we are narrowing that search, and hopefully we will have a new chief medical officer at our next board meeting to at least announce who that will be. But they were really terrific candidates. I think it was a terrific process, and really want to congratulate everybody on that search committee that helped throughout the process and moved it as quickly as possible. Erlanger East is moving ahead of schedule, which is really great. And I really want to lift up one thing, is that over 65% of the actual construction is being completed by local firms. That relates to over $32 million of the $50 million project is being directed to local construction firms. And I just really want to acknowledge Dr. Phil Jackson and the whole Erlanger East team for that project. Is going really, really well. Sodexo, we did change vendors. Sodexo is hitting the ground really strong, and I think they're doing a very good job. I think there's a lot to do to improve the food and the housekeeping here, but I think they're the right team, local, and they have a lot of knowledge, and hopefully the dinner was a little improved.
Mr. Spiegel,
Yes.
on that one, did the people who work here retain their positions?
Yeah, everybody did. everybody did. Some management positions are changing.
The management team from Aramark did not stay, but all of the local employees, yes, they did stay.
Physician quarterly staff meeting, Dr. Kern and myself, we're going to present to the entire medical staff, and I'm going to give a State of the State address to the medical staff. Dr. Kern will give the medical staff report, and we are expecting a tremendous turnout. I do invite all the board members to try to attend the quarterly medical staff meeting. I think, Mr. Chairman, that's my report.
Very good. Thank you very much. I do have a few items, just first of all, the dinner. We're about to get the timing of our new schedule, I think, worked out. I hope 30 minutes was too short to eat, an hour was too long. We start dinner at 45 minutes before. If anybody doesn't like that, let me know and we'll try to. And we are ordering a little bit more robust. It's a word I use because some of my trustees like a more robust dinner, and we're going to try next month to get that done with Sodexo. We're looking forward to that. THA, the meeting is coming up. Ron Loving was our trustee that was the point person for THA, and he attended, I guess, the meetings every year. Since Mr. Loving has rotated off the board, we don't have a champion to attend THA, and it's really needed. We need a champion to get involved, to report back to the board on what's going on and be involved in that. And so can Mr. Spiegel or Greg or somebody explain to the trustees what, I mean, when I got the invitation for 3 days to go to a 3-day meeting, I said, hey, Greg, I can't do this. So I'm like, so let's talk about it at the trustees.
I think we have to first explain, THA is the advocacy group of hospitals. And I'm on the board of directors. Ron Loving was involved in the leadership and represented the trustees not only here locally but on a statewide level. And I think it's very important for our board to be actively involved in issues that face healthcare and hospitals across the state. Erlanger is a recognized institution. We're the 7th largest public hospital in the United States, and we probably serve more larger area than any other hospital in the state of Tennessee. It's really important that our trustees are involved in the statewide issues. There are advocacy days. Dr. Miller and Dr. Shoemaker serve also in the Tennessee Medical Association and the Hamilton County Medical Association. These are very important advocacy groups as well, and how they all work together on a statewide issue to actually reduce costs and improve care across our state is an important aspect both of the taxpayers and the TennCare program and how care is provided for our physicians and the patients. And I just really think it's really important for one of the board members to represent not only Erlanger, but to advocate for health care on a statewide basis. One of the other things that Mr. Loving did, he also was the THA representative for the American Hospital Association. And that was an elected position amongst the trustees from THA. And so he actually served on a national level as well. And it brought not only prestige, but brought the advocacy from East Tennessee on a national level. I think it's important for one of the trustees to serve as a member of the trustee group as part of the THA.
Thank you. I do. If someone has, one of my trustees has the time, and I will draft or send out an email to our trustees that aren't here this evening, because we've got several of them out, to try and find somebody that would champion that cause. So think about it. If you're willing, see me. And yes.
No, I might just add one thing. The same thing Kevin said. When I first came on the board, Ron got me to go to THA and AHA.
Right.
Keep wanting to say AHA. But it really is a neat thing to get involved with if your day job allows you. I mean, it does take some time, but it's really
And
very
the-
interesting. And I enjoyed that. Those are real dynamic, engaging meetings. And you learn a lot.
You really do.
From them, so.
So let's take that on as a mission to see if we can't get one of our trustees to sign on to that and represent us on that.
And it brings recognition to us, too.
It surely does. So, and the meeting is, maybe we can get somebody to sign. I'm probably going over for one day of the meetings, but it's September the,
Is it the 29th or 30th?
so, toward the end of
Early
September.
October.
So you have time to sign up someone. So with that, let's see. Let's see if I have anything else to go over. Kitty will be reaching out to you, trying to find a date for our strategic planning retreat. Probably be kicked down to January sometime. So we're trying to coordinate that. Does anybody else have anything else? Trustee Stanley.
I do. Since we're talking about quality tonight, I wanted to talk a little bit more about quality. And in particular, one of the things I've just been thinking about is over the last year with the financials stabilized, volumes are up, surgeons are back, we've been on non-divert and really reestablished a presence in the region. All of these things are fantastic, but when you get a surge in demand, it can put a strain on the system. And so I just want to understand a little bit more while we are kind of waiting for that the new physical space to come online, which we all understand takes a while, and we should rightfully celebrate that. What's being done now to help make sure that the patient experience and also the medical staff experience of getting patients moving through the hospital in a reasonable time, ED wait times, if someone's had a surgery, they've got a place to go to on the floor and they're not waiting too long. I want to understand a little bit more about the short-term plan for that.
Jennifer, that's a great comment because it is a strain. I'm going to go into a whole lot more detail on Monday with the medical staff, but maybe Rob Brooks can give us an update of all the things we're doing right now.
Thank you.
And great observation, and we've been doing a lot to try to do some short-term fixes while those long-term strategic fixes are in place. And so what we've done is scoured the entire system to find beds that we could open quite quickly. And the first 12 that we did identify were at North. And so those are open, and they're both taking admissions from the emergency department at North, as well as acting as a buffer for some patients that spend a lot of time here waiting for their next level of care. An example of that is there's a Medicare law that if you are going to be requiring a nursing home stay, you have to stay in the hospital for 3 days, regardless if you're ready to leave or not.
Really?
So if your loved one was malnourished at home and goes and sees their primary care physician and you're ready to place them into a nursing home, they have to first go stay at a hospital for 3 days. So not our rule, but we have to follow it. So when some of those types of patients are showing up here that don't require a really high level of care, we're now working with our case management and the hospitalists to transfer those patients to North as well, to open the higher acuity beds here for us. So as North continues to fill up those first 12 beds, we'll continue to open additional beds at North. Something else we've done here is that in the previous years when the census was down and you had all these empty rooms, they got adopted into other uses such as closets and offices and sleep rooms. And so our engineering team and Jan Keys and the nursing team are identifying all of those rooms that are still capable of taking patients, and we're converting them back into patient care rooms. So we opened 5 last week on the 5th floor. They found an additional 3 here recently, and they're basically going to go floor to floor and look in every door and find how many rooms we can get to convert back to patient care immediately.
How long does it take to do something like that?
So those 5 that they found were sleep rooms. They were being used for on-call at night for if a physician comes in and he's too tired to leave, or if for full-time on-call people. They turned those over in 50 hours, I think.
Oh.
So John and the engineering team did a phenomenal job. They gutted the room, they painted it, they cleaned the floors, they put it in the nurse call system, and they turned it back over to us in about 3 days' time, and I think it's full now.
Right. Could I say something on
Sure.
that too? I'd like to recognize John because I want to just tell you, we started talking about the rooms. We went up there and looked. I happened to go back about 2 hours later. They were already there. Painters were already going. Much to this dismay, we didn't have even time to communicate. So we did have a little glitch in the communication, but everybody rallied and come back. But that was a phenomenal job. Now, granted, they were not an office, so they were still had everything in place, such as med gases and all that. But that was such a phenomenal job. I like to recognize John and his crew because they were just Johnny on the spot and got it done. So I
So
appreciate it.
if it wasn't, just so I understand this is interesting, like if it was a patient room before and it's an office now, it will take longer to turn it around, but the gas lines and everything
Everything's
would
still
be in
there.
place.
Still
They were
there.
never taken out. They just put a desk in there and, a bookcase, and it's a patient room on that floor, but maybe it's the assistant nurse manager's office, and so we'll relocate those to non-patient care areas.
And one more thing on that, because I did acknowledge John. I want to also acknowledge Tracy Jefferson and Dr. Woods Blake. We were here one night probably till 11 o'clock, walking and trying to find places where we had misplaced people. But we managed to do that, and we found everybody a really nice home. In fact, most of them said, hey, this is better than what I had. So we got through, but I wanted to acknowledge that group too. So they did a great job. Thank you.
Thank you very much.
And then there are several things that we're doing to streamline the flow, which will help to decrease our length of stay. So if we can decrease our length of stay by 1 day and you're doing 100 admissions a day, that's 100 additional beds that you would actually free up. So some of those are that we're, again, identifying those difficult placement patients, and the nursing home is only one example. Because we serve an entire region, if we get a trauma patient flown in here from an hour and a half away, they're going to go back to rehab usually in that community if they have it available. So our case managers have to coordinate that care, get the insurance approval, all of those things. We're trying to start that much sooner in the stay, so they're identifying those hard to place patients 24 to 48 hours before their expected discharge, so they can get a lot of that legwork done ahead of time instead of at the time of discharge starting that process. Something else is that Health South, which is a rehab facility that we work with, was discharging their patients at 2 or 3 in the afternoon. Then they'd have to clean the bed, and so our patients couldn't get in there until 5 or 6 in the evening. Britt and Jan worked with Health South. They're now discharging their patients at 9 a.m. so that we can send our patients there by 11. And it is, anybody in here knows, most of our discharges start about 11 or 12 and peak up through about 3 to 4 o'clock in the afternoon. So the earlier we can get the discharges out, the better off we'll be. Another thing on discharges is, again, because we're a large region, we may get somebody brought in here, whether it's for a medical reason or trauma, and they're discharged at 9 a.m., but their wife is at work in Cooksville and she can't be here till 7 that evening. Traditionally, we let that patient sit in the room, this is if it's a hotel, and hang out until the ride shows up. So we're working on creating discharge lounges in areas where that discharged patient that's going home and just waiting for a ride can go and sit and wait for that ride instead of taking up a patient care space where we could bring up another patient.
How long will it take to create something like that?
They actually exist already on a lot of the floors. It's getting the process in place and ensuring that the process is working appropriately. And so we will be working on that. And then the final thing that's being worked on is geographic rounding. So we did a pilot study with our hospitalists where they kept a geographical book of patients instead of having them all over. And so those were their patients every day for the entire week. It worked out great from the staff and from the patient perspective because they had the same doctor every day. And that pilot study was very successful, and I think it decreased length of stay by a whole day. But in order to do that, we have to really reduce the load that's on the hospitalists. So we're working to have one up in September and another, or 2 floors up in September, 2 more up in October. And then the goal is that they will all be up by January 1. In order to do this, though, we have to alleviate them from doing rounds in the intensive care units, which we are working on through the recruitment of a new chief of critical care medicine, having critical care physicians cover those ICUs, which would free up the hospitalists to go and do these geographical rounding things. So again, a lot of things in motion. And when we went over all of this with the medical staff, to our pleasure and also probably dismay, they said, that'll be great, but as soon as we clean those up, we think we're going to fill them up again. So We do have to start thinking long-term in, as we continue to grow as a provider in the region, and if the population in the region continues to grow, what our future, stance will be on a new patient tower and things like that. And then also on the physician offices, both at the retreat and I believe Monday, you'll see how much our physician office visits have grown by. They've grown dramatically, which is a good thing. But there are some things that we're doing to make that experience both better for the patient and to make sure that we can get those visits in. One is that the phone system was found to be woefully inadequate, and Tish and her team have worked to get a brand new phone system put in. They trialed it in 2 or 3 offices. It works phenomenal. You never have more than 2 pushes before you're talking to a human, which is great. I know that is frustrating for me and everyone else.
Thank you so much.
So if you go beyond 2 things, you have what you want, it'll immediately go to an operator that can help you. So they're now, I think, deploying those out to the rest of the physician offices soon. And then the second thing is that we implemented a technology called ZocDoc. So you can go on your device and go to your app store and look up ZocDoc. It's a nice little app. You click on it, it'll show you every physician. Right now it's exclusive with us that's within the area that has an appointment tomorrow. So not next
I'm on
week.
it. Are all the physicians loaded?
All of our primary care physicians.
Okay, so it's not all the specialists.
Right. Not yet.
But they're planning on rolling
Get them
out.
on, get
Yes,
them on.
yes. So we wanted to work the glitches out first
Yeah.
with
Yeah.
primary care, and there were some like anything else, but it's embedded into their scheduling system. So if they have 3 openings in their schedule tomorrow, they can see that and pick that and come tomorrow and go to the physician. So
This is your employed physician. That's your
Right,
employed
correct.
physicians, not your community
Right.
affiliated physicians.
But
We
we
will
can,
roll
that
it out.
doesn't, we can roll it out to
Yeah.
those community physicians that's affiliated. So if you're interested, please get with us, because
Yeah.
we can actually get that going quickly for you.
And I saw Dr. Melanie Blake yesterday at a meeting, and she said so yesterday was Wednesday. On Tuesday, we had 100 scheduled visits via ZocDoc in one day.
So would something like this enable, like the board to see a future report on like average wait to an appointment, average like cancellations, like just so we can get a better pulse of what's happening in the
I
physician
mean, it's still
services
really
area?
early, but yeah, I think data and reporting is what we're really looking for, and the variability of physician scheduling and the days of the week is, Friday afternoon. I mean, so we're gonna look at all those things and, be careful what you wish for, you may get it. So that was the thing about not waiting for Epic's implementation, but we really wanted to, implement automation earlier, and that's why we were first to market with ZocDoc in this community. It's been very, very successful in other markets, and one of the things when we were at HRSA and talking to the federal government about implementing ZocDoc at the health centers, they said, oh, we have it in Washington. That's the only way we make appointments. So, that it's new to us, but in other major cities, it's not new. And it's the way things are being done. So it's exciting.
Rumor even has it you're looking at taking over my office upstairs, I think, so I don't know, but.
We need to find Dr. Coe for an office.
Yes.
Where that is, we
That's the
don't
latest
know.
rumor I've heard, so, touche. Yes.
Robin, is this facility across the hall over here, I forgot the name of it.
Iraq?
Yeah, has that impacted how we handle the patient flow?
Oh, yeah.
Yeah, it is a big
Is it
key
making it better or
component.
worse?
There are some things that we're working on to streamline, because we have a system called teletracking, which is a bed tracking management system, and it has a lot of utilities that we haven't tapped into yet. And so we're working with Robbie Tester and the folks from teletracking to give us what are those best practices that people have seen are the most useful in getting those implemented. And so while it is all in one room and it is great, there are still things that we can leverage from in there to make things even better.
Very good. My trustees have any other questions, or thank you for that information. That is on all of our minds. So, is there anything else to bring before this trustees tonight? If not, I will remind you, the trustees, we do have a closed legal and credentialing meeting right after this upstairs. We shouldn't take too long. And if nothing else, this meeting is adjourned.